Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we'll delve into the world of non-malignant leukocyte disorders, exploring the fascinating changes that can occur in white blood cells. From neutrophils to lymphocytes, we'll uncover the underlying causes and morphologic abnormalities of these disorders. Let's get started. Pelger-Huët anomaly, PHA. Our first disorder is Pelger-Huët anomaly, also known as PHA. This condition is inherited and falls under the category of true or congenital PHA. PHA is characterized by a reduction in the segmentation of cell nuclei, leading to bilobed or unilobed shapes and distinct clumping of chromatin. These nuclear structure alterations affect various types of white blood cells, with fully developed neutrophils showing the most noticeable changes. The United States, approximately 1 in every 4,785 individuals is affected by PHA. So, what causes this anomaly? Well, it's all in the genes. PHA is caused by a genetic mutation in the lemon beta receptor gene. The lemon beta receptor is a protein found in the inner nuclear membrane, and it plays a significant role in nuclear shape changes during leukocyte maturation. Mutations in the lemon beta receptor gene lead to the characteristic morphological changes seen in PHA, though the exact mechanisms are still under investigation. Now, let's take a closer look at the nuclear shapes affected by PHA. Nuclei impacted by this anomaly can take on various forms, including round, ovoid, and peanut-like shapes. You might even observe bilobed forms, where nuclei are connected by a thin filament, creating a spectacle-like appearance. The manifestation of PHA can differ between individuals. In homozygous cases, all neutrophils will have round nuclei. On the other hand, heterozygotes show the anomaly in 55% to 93% of neutrophils, often with mixed nuclear shapes. Interestingly, despite the altered nuclear appearance, neutrophils in PHA usually function normally. These white blood cells continue their essential role in defending the body against infections and foreign invaders. Pseudo or acquired Pelger-Huët anomaly. Neutrophils exhibiting PHA-like features aren't just limited to congenital cases. In fact, they can appear in individuals battling blood-related cancers like myelodysplastic syndromes, acute myeloid leukemia, and chronic myeloproliferative neoplasms. But that's not all. These pseudo or acquired PHA neutrophils can also be found in patients dealing with conditions like HIV infection, tuberculosis, mycoplasma pneumoniae, and severe bacterial infections. Certain drugs can also induce pseudo-PHA, including mycophenolate mofetil, valproate, sulfasoxazole, ganciclovir, ibuprofen, as well as chemotherapy drugs like paclitaxel and docetaxel. Now, let's delve into the challenges faced in the laboratory when dealing with Pelger-Huët anomaly, whether it's true or pseudo. Distinguishing between true PHA and pseudo-PHA can be quite complex. In true PHA, a higher percentage of cells exhibit PHA morphology compared to pseudo-PHA, around 63% to 93% versus less than 38%. While all white blood cell lineages can be affected in true PHA, pseudo-PHA primarily occurs in neutrophils, except in certain cases of MDS where other cell types may also show PHA morphology. The process of cell identification itself comes with its own set of challenges. Pelger-Huët neutrophils can have different shapes, round, oval, or peanut-like, leading to potential misclassification as myelocytes, metamyelocytes, or band neutrophils. Differentiating between mature Pelger-Huët cells and less mature neutrophils requires careful analysis of chromatin structure. Immature neutrophils should display some degree of cytoplasmic basophilia, which is absent in PHA cells due to their maturity. And here's where things get interesting: the labeling dilemma in reporting PHA cells. Standard labels like segmented neutrophil or band neutrophil may not accurately represent PHA cells. A suggested solution: apply a single label for all PHA neutrophil variants, such as categorizing them as others, and then defining others as Pelger-Huët neutrophils. Establishing standardized labels ensures that clinicians understand the presence of PHA cells and have the correct lineage maturity information. Neutrophil hypersegmentation and myelopathexis. Let's start by understanding neutrophil hypersegmentation, a phenomenon that provides clues about underlying health conditions. Normally, healthy neutrophils have 3 to 5 lobes separated by filaments. Hypersegmented neutrophils, characterized by more than 5 lobes, are often associated with megaloblastic anemias. These enlarged neutrophils are larger than regular ones and are commonly observed in conditions like megaloblastic anemias. But that's not all. hypersegmented neutrophils can also be indicative of myelodysplastic syndromes, a form of myeloid dysplasia. In rarer cases, hereditary neutrophil hypersegmentation can lead to this condition. Interestingly, unlike other conditions, hereditary neutrophil hypersegmentation is distinct. Individuals with this genetic disorder don't display symptoms or signs of megaloblastic anemia. Now, let's delve into myelopathexis, a rare hereditary condition that affects neutrophil behavior. Despite normal granulocyte production, a unique problem arises in the release of these cells into circulation, leading to neutropenia. The impact on neutrophil morphology is quite striking in myelopathexis. Neutrophils may appear overly mature, displaying features like hypersegmentation, hypercondensed chromatin, and pycnotic changes. Additionally, the presence of cytoplasmic vacuoles is observed, a telltale sign of this condition. Myelopathexis isn't alone, it's a component of a rare inherited disorder known as WHIM syndrome. WHIM syndrome is characterized by a combination of distinct features: warts, neutropenia, hypogammaglobulinemia, infections, and myelopathexis. Let's uncover the mechanism behind myelopathexis. Mutations in the CXCR4 gene lead to an overly active CXCR4 receptor and its binding to ligands. This abnormality disrupts the normal balance and movement of cells, causing neutropenia, lymphopenia, and hypogammaglobulinemia in affected individuals. Now we have Alder-Reilly anomaly, an inherited trait that leads to unique features in granulocytes. This anomaly is inherited in a recessive pattern and is characterized by distinct features in granulocytes. Granulocytes contain larger metachromatic cytoplasmic granules that stain darkly. These granules are called Alder-Reilly bodies or Reilly bodies. These bodies are primarily composed of partially digested mucopolysaccharides. Interestingly, they may resemble the appearance of heavy toxic granulation. Unlike toxic granulation, Alder-Reilly anomaly doesn't show typical signs like neutrophilia, dull bodies, or a left shift. What's fascinating is that Alder-Reilly bodies aren't exclusive to neutrophils, they can be found in granulocytes, lymphocytes, and monocytes in some patients. This sets it apart from toxic granulation, which is specific to neutrophils. Now, let's understand the impact and conditions associated with Alder-Reilly anomaly. The core issue in Alder-Reilly anomaly lies in the incomplete breakdown of mucopolysaccharides. These bodies are commonly linked with certain conditions like Hurler syndrome, Hunter syndrome, and Marittos-Lamy polydystrophic dwarfism. Remarkably, Alder-Reilly anomaly doesn't impact the function of leukocytes. This ensures that cellular activities remain intact despite the anomaly. Moving on to chidiakagashi syndrome, a rare and severe autosomal recessive disorder. This syndrome involves an unusual fusion of granules in various cells throughout the body. These fused granules tend to be large and generally don't function properly. The effects of chidiakagashi syndrome extend beyond blood cells, they impact diverse areas like hair, skin, glands, and nerves. Hematologic findings include oversized lysosomal granules within granulocytes, monocytes, and lymphocytes. The fusion of granules leads to malfunctioning white blood cells, contributing to recurrent infections. Abnormal dense granules in platelets can lead to bleeding issues. Chidiakagashi syndrome is linked to a specific mutation in the CHS1LYST gene located on chromosome 1q42.1-2. This gene encodes a protein vital for processes like vesicle fusion or fission. Mayheglin anomaly, a rare condition that has more to it than meets the eye. Passed down in an autosomal dominant manner, this anomaly involves platelets and presents some key features. One striking feature is the presence of unusually large platelets, along with variable levels of thrombocytopenia, or low platelet count. But here's the twist: Mayheglin anomaly doesn't only affect platelets. It also impacts other blood cell types like neutrophils, eosinophils, basophils, and monocytes. These cells exhibit intriguing inclusions similar to dull bodies, a microscopic wonder. This anomaly is caused by a specific genetic mutation involving the MYH9 gene located on chromosome 22q12-13. The mutation leads to abnormal production of myosin heavy chain type IIA, which affects both megakaryocyte maturation and platelet fragmentation. Those fascinating dull body-like inclusions are made up of precipitated myosin heavy chains. Interestingly, most individuals with Mayheglin anomaly don't show noticeable symptoms. However, a few might experience mild bleeding tendencies. Let's shift to normal morphology with functional abnormalities. The majority of genetic functional leukocyte disorders, with the exception of some of the storage disorders, are not characterized by specific morphologic alterations in leukocytes. Now, let's dive into the world of chronic granulomatous disease, quite the mouthful. This rare inherited disorder affects immune cells' ability to produce superoxide and reactive oxygen species. The issue lies in gene mutations related to the NADPH oxidase complex, a team of proteins crucial for generating antimicrobial agents. During a normal immune response, granules with helpful enzymes and molecules come together to form NADPH oxidase. Most cases of CGD are either X-linked recessive or autosomal recessive, and the specific gene mutations impact disease severity. Patients often face bacterial and fungal infections affecting various body parts like the lungs, skin, and more. Improved treatments, like antifungal agents, have significantly increased survival rates. Diagnostic tests play a crucial role in identifying these conditions. For Mayheglin anomaly, genetic testing can confirm the MYH9 gene mutation. In chronic granulomatous disease, the nitroblotetrazolium reduction and flow cytometry are key tests for diagnosis. To understand leukocyte adhesion disorders, we must first grasp the intricate process of inflammation. When inflammation strikes, white blood cells, or leukocytes, rush to the scene. This involves capturing, rolling, and migrating from the bloodstream into tissues. Selectins on leukocytes bind with their counterparts on cell surfaces, initiating the adhesion process. High-affinity interactions occur between integrins and endothelial cell receptors, leading to binding and structural changes in leukocytes. Leukocytes reshape and spread, allowing them to move from blood to tissues. But leukocyte adhesion disorders, LADs, disrupt this crucial process. LADs are rare inherited disorders caused by mutations in genes responsible for adhesion molecules. This prevents neutrophils and monocytes from sticking to endothelial cells and migrating to tissues. LAD-I results from a mutation affecting beta-2 integrin subunits, leading to infections, neutrophilia, and skin issues. LAD2 is caused by defective fucose transport impacting selectin ligand synthesis, causing growth and physical deformities. LAD3's Kindlin-3 mutation impairs leukocyte activation, causing immunodeficiency, recurrent infections, and bleeding issues. LADs disrupt the immune response, increasing susceptibility to infections and associated health challenges. Now, let's explore some intriguing miscellaneous granulocyte disorders. Myeloperoxidase, MPO, deficiency is a unique condition characterized by the absence of a key enzyme in neutrophils and monocytes. MPO helps produce hypochlorite and hypochlorous acid, a potent defense against microbes during phagocytosis. Inherited in an autosomal dominant manner, MPO deficiency affects around 1 in 2,000 individuals. A mutation in the MPO gene on chromosome 17 leads to this condition. Most patients don't face recurring infections because alternative pathways compensate for microbe killing without MPO. Acquired MPO deficiency can be linked to hematologic neoplasms and lead poisoning. In the hematology lab, the Siemens ADVIA analyzer detects MPO deficiency, aiding in automated differential identification. Let's embark on a quest to understand monocyte/macrophage lysosomal storage diseases, which can be categorized into mucopolysaccharide storage diseases and lipid storage diseases. Mucopolysaccharidoses, MPSs, are a group of inherited disorders that affect the degradation of glycosaminoglycans, GAGs. Deficient enzyme activity leads to a buildup of partially degraded GAGs in lysosomes, resulting in physical abnormalities and potential mental retardation. MPSs are classified based on specific enzyme deficiencies, the type of stored GAG, and the severity of symptoms. Clinical features of these disorders can be elusive. Peripheral blood might seem normal, but metachromatic Reilly bodies could be present in various cell types. Bone marrow examination may reveal macrophages containing abundant metachromatic material. The diagnosis involves testing for specific enzyme deficiencies, aiding in accurate identification. Treatments like enzyme replacement therapy and hematopoietic stem cell transplantation offer hope for managing these conditions. Let's switch gears and explore some intriguing miscellaneous lipid storage diseases. Gaucher disease is a common lysosomal lipid storage disorder. It's caused by a deficiency in the enzyme beta-glucocerebrosidase, crucial for glycolipid metabolism. This autosomal recessive condition is more prevalent among Ashkenazi Jews due to genetic mutations. Over 300 genetic mutations have been identified for Gaucher disease, leading to a range of symptoms. Accumulated glycolipids affect macrophages throughout the body, including osteoclasts and microglia in the brain. Gaucher disease diagnosis involves the clinical triad, bone marrow examination, and serum phosphatase levels. Distinct macrophages called Gaucher cells are present in bone marrow, often showing a striated appearance. Chitotriosidase and other biomarkers aid in gauging disease severity and monitoring. All forms of Gaucher disease carry an increased risk for developing hematologic malignancies. Treatment include enzyme replacement therapy and other agents are key treatments for Gaucher disease. Pseudo-Gaucher cells can appear in certain conditions, often due to increased cell turnover like thalassemia, chronic myelogenous leukemia, and acute lymphoblastic leukemia. Now, let's delve into Niemann-Pick disease, divided into three types, A, B, and C. Niemann-Pick types A and B are caused by recessive mutations in the SMPD1 gene, resulting in a shortage of acid sphingomyelinase, ASM, leading to an accumulation of sphingomyelin in the liver, kidneys, and lungs. In both A and B, Niemann-Pick cells are common in bone marrow. These cells are macrophages with foamy cytoplasm, loaded with lipid-filled lysosomes that show up as vacuoles after staining. Type A emerges in infancy, causing failure to thrive, hepatosplenomegaly, and rapid neurodegeneration, often leading to death by age 3. Type A has minimal sphingomyelinase activity. Type B appears later in life with diverse symptoms. Neurological issues are less common, but severe hepatosplenomegaly, heart conditions, and lung problems often occur. Niemann-Pick type C involves reduced cholesterol movement, leading to accumulation in macrophage lysosomes. Movement from endosomes/lysosomes to the cytosol. This process normally involves Niemann-Pick CI and Niemann-Pick C2 proteins. Mutations in these genes cause NPC, leading to cholesterol, bisphosphate, and sphingolipid accumulation in macrophage lysosomal storage organelles. Type C disease presents with systemic, neurologic, and psychiatric symptoms. Prognosis is bleak, with many patients not surviving beyond 25 years. Next, we're unraveling the mysteries of genetic B and T lymphocyte abnormalities, shedding light on disorders that impact our immune warriors. Prepare to dive into the fascinating world of genetic abnormalities affecting B and T lymphocytes. These disorders often lead to reduced production of these crucial immune cells, leaving individuals more vulnerable to infections and secondary cancers. Let's start with DiGeorge syndrome, a T lymphocyte abnormality. It's characterized by an underdeveloped thymus, resulting in fewer T cells. This condition is linked to a microdeletion on chromosome 22q11.2, occurring in about 1 in 3,500 births. People with this deletion face a spectrum of challenges, including parathyroid gland issues, heart abnormalities, abnormal facial development, neurologic disorders, and low calcium levels. A small percentage experience complete DiGeorge syndrome, lacking a thymus. Thymus transplantation is a treatment option, with a roughly 75% survival rate. Moving on to XLA, or sex-linked agammaglobulinemia, a B-cell disorder usually caused by mutations in the gene encoding Bruton tyrosine kinase, BTK. These mutations lead to decreased BTK, vital for B-cell development and function. Without it, B lymphocytes fail to mature and face an early demise. XLA symptoms typically emerge after maternal antibodies clear from an infant system, around 1 to 2 months old. Repeated bacterial infections become life-threatening. Let's now explore combined B and T lymphocyte abnormalities, encompassing conditions like severe combined immunodeficiency, SCID, and Wiskott-Aldrich syndrome. SCID, a complex condition, can be categorized into adenosine deaminase deficiency and X-linked SCID. Both types result in reduced T, B, and natural killer, NK, lymphocytes. Adenosine deaminase deficiency leads to lymphocyte depletion due to excess natural substrates. X-linked SCID, more common, is caused by a mutation in the gene for the IL-2 receptor gamma chain, shared by several interleukins. Our journey wouldn't be complete without Wiskott-Aldrich syndrome, an X-linked disorder caused by a mutation in the WASP gene. This leads to low or absent levels of the WASP protein, resulting in immunodeficiency, eczema, and low platelet counts. The absence of WASP impacts the movement, adhesion, and activation of various immune cells like T cells, B cells, and NK cells. Let's explore the world of quantitative abnormalities of leukocytes, focusing on those mighty defenders known as neutrophils. Before we dive in, remember, the reference range for white blood cells, including neutrophils, can vary based on age. Always consult reliable sources for accurate values. Neutrophilia, the surge in neutrophils, occurs when they exceed 7.0 times 10 to the power of 9 divided by L in adults and 8.5 times 10 to the power of 9 divided by L in children. Typically, they make up 50% to 70% of white blood cells, but absolute values provide a clearer picture. The absolute neutrophil count, ANC, includes segmented, band neutrophils, and sometimes metamyelocytes or myelocytes. Factors like exercise, stress, shock, burns, or medical conditions can cause neutrophilia, stemming from increased production or a shift from storage to circulation. Ever heard of a leukocyte reaction? It's a reactive surge in white blood cells, often above 50 times 10 to the power of 9 divided by L, with plenty of immature neutrophils. Usually triggered by infections, metabolic issues, inflammation, or response to cancer. Beyond neutrophils, it can involve other white blood cell types. Sometimes, a neutrophilic leukocyte reaction can mimic chronic myelogenous leukemia. Now, let's talk leukoerythroblastic reaction, where immature neutrophils, nucleated red blood cells, and teardrop-shaped red cells coexist. This reaction often accompanies increased neutrophils, but not always. It's a hint of possible bone marrow issues, like tumors, fibrosis, lymphoma, leukemia, or even an excess of normal marrow cells. Neutropenia is when the absolute neutrophil count drops below 2.0 times 10 to the power of 9 divided by L in white adults or 1.3 times 10 to the power of 9 divided by L in black adults. As counts decrease, infection risk rises, especially below 1.0 times 10 to the power of 9 divided by L. Severe neutropenia, below 0.5 times 10 to the power of 9 divided by L, is even riskier. Agranulocytosis is when neutrophils plummet below 0.5 times 10 to the power of 9 divided by L. Neutropenia's causes include rapid neutrophil removal, reduced bone marrow production, ineffective production, or shifts in the circulating to marginal neutrophil ratio. Picture this, a low level of neutrophils, the valiant white blood cells in our immune army. Neutropenia can be classified into two categories, inherited and acquired. The majority of neutropenia cases are acquired, often resulting from immune-related factors, autoimmune disorders, medications, infections, and more. Immune-mediated neutropenia occurs when antibodies latch onto neutrophil antigens. Ever heard of alloimmune neonatal neutropenia? It's when maternal antibodies affect newborn neutrophils. Autoimmune neutropenia in children is a primary condition, characterized by antibodies against specific neutrophil components. Interestingly, it usually fades away within a few years. Secondary autoimmune neutropenia can be linked to disorders like rheumatoid arthritis or lupus. Surprisingly, over 100 drugs can also lead to neutropenia. Drug-induced neutropenia might arise due to drug toxicity or an immune response. Infections, particularly viral ones affecting bone marrow cells, can also trigger neutropenia. Now, let's talk about those rare genetic conditions, inherited neutropenias. These result from issues in neutrophil production within the bone marrow. Though they increase the risk of infections, treatments like antibiotics and colony-stimulating factors have enhanced patient outcomes. Ever heard of Shwachman-Diamond syndrome? It's a genetic disorder impacting the bone marrow, pancreas, and skeleton. A common hematologic feature is fluctuating neutropenia, often accompanied by anemia and low platelet counts. Now, let's shine the spotlight on Shwachman syndrome, a condition marked by severe neutropenia and bone marrow concerns. Cyclic neutropenia, on the other hand, presents periodic bouts of severe neutropenia, typically every 21 days. Thankfully, G-CSF treatment helps manage these events effectively. Chronic idiopathic neutropenia mainly affects adult women. It brings variable bone marrow changes and an increase in immature neutrophils. The severity often corresponds to the degree of neutropenia, and G-CSF proves to be a valuable treatment. Fanconi anemia, a rare inherited disease, comes with bone marrow challenges, cytopenias, and a heightened risk of cancer. And finally, dyskeratosis congenita, a genetic disorder with a diverse range of symptoms. From skin and nail abnormalities to bone marrow failure and an elevated risk of cancer. Let's begin with eosinophils, those enigmatic cells influenced by various factors, from bone marrow activity to tissue movement and cell survival. When the absolute eosinophil count exceeds 400 million per liter, we enter the realm of eosinophilia. Non-malignant causes often involve the stimulation of cytokines like interleukin-3 and interleukin-5. Eosinophilia's root causes vary across underdeveloped and developed regions. Parasite infestations are common in underdeveloped areas, while allergic conditions like asthma and hay fever dominate in developed countries. Other triggers can include HIV, fungal infections, autoimmune disorders, and even some cancers with cytokine abnormalities. Ever heard of hypereosinophilic syndrome or HES? It's marked by persistent eosinophilia lasting over 6 months without an identifiable cause. This condition falls under the umbrella of myeloproliferative neoplasms. On the flip side, there's eosinopenia, when eosinophil count drops below 0.09 times 10 to the power of 9 divided by L. This could stem from various causes like infections, inflammation, autoimmune disorders, stress, or even certain medications. Now, let's shift our focus to basophils, another intriguing group of white blood cells. Basophilia occurs when the absolute basophil count goes beyond 150 million per liter. While chronic myelogenous leukemia stands as a common malignant cause, non-malignant triggers encompass a diverse range, from allergic rhinitis to chronic infections and even hypothyroidism. Hypersensitivity to drugs or food, chronic inflammatory conditions, and even bee stings can contribute to basophilia. Monocytes, those versatile immune cells that often take center stage during inflammation and immune responses. Monocytosis, when the absolute monocyte count rises above 1.0 billion per liter in adults or 3.5 billion per liter in neonates, can occur due to various non-malignant conditions. Monocytes are multitaskers, they partake in inflammation, infections, immunological reactions, and even tissue repair. Interestingly, monocytosis can indicate a positive recovery from severe infections or neutropenia. Sometimes, administering G-CSF or GM-CSF can lead to reactive monocyte changes, resulting in monocytosis. This condition is also linked to certain neutropenic disorders, like cyclic neutropenia. However, monocytopenia, where absolute monocyte count drops below 0.2 billion per liter, is rare and typically associates with conditions like aplastic anemia or chemotherapy-induced cytopenias. Monocytopenia can emerge in patients receiving steroid therapy, undergoing hemodialysis, or battling sepsis. Viral infections, especially Epstein-Barr virus, EBV, can also contribute to monocytopenia. Moving on to lymphocytes, those small yet mighty cells that wield immense influence over our immune responses. Lymphocytosis, characterized by an elevated number of lymphocytes in the blood, varies in definition based on age. In children between 2 weeks and 8 to 10 years, higher absolute lymphocyte counts are typical. Young children, lymphocytosis starts at an absolute lymphocyte count above 10.0 billion per liter, while in adults, the threshold is higher, at 4.5 billion per liter. Remember, the reference range for relative lymphocyte percentage is around 20% to 40%, but it's absolute numbers that truly define lymphocytosis, not just relative percentages. Lymphocytoses come in 2 flavors, those with reactive morphologic alterations and those without. These subdivisions offer valuable insights into various immune responses. We're diving into the fascinating realm of blood cells and their captivating morphologic changes. Get ready to explore the microscopic wonders that play a crucial role in our health. In this comprehensive guide, we'll be covering everything you need to know about qualitative, morphologic, changes in various blood cells. From neutrophils to lymphocytes, we'll unravel the secrets hidden within these tiny yet mighty warriors. So, let's jump right in. Our first stop on this journey is the realm of neutrophils, the frontline defenders against infections. 1. Reactive response. Neutrophils, those vigilant guardians, can exhibit remarkable morphologic changes in response to various triggers, think infections, inflammation, stress, or even therapy. What might seem abnormal is often a part of the body's calculated response. 2. Types of morphologic changes. Behold the left shift. This term refers to changes in the types and numbers of circulating neutrophils, revealing the ongoing battle within. It comes in varying degrees. Mild left shift, a hint of change with increased band neutrophils and metamyelocytes. Moderate left shift, metamyelocytes, myelocytes, and the occasional promyelocyte step onto the stage. Marked left shift, an intense performance with myelocytes, promyelocytes, and an occasional blast form in the spotlight. 3. Reactive morphologic changes. Let's explore some key players in the neutrophil's visual repertoire. Toxic granulation, dark, blue-black granules, these aren't just for show. They contain acid mucosubstance, enhancing microbial destruction during inflammation. Dull bodies, cytoplasmic inclusions hinting at the cell's history, remnants of ribosomal RNA, often dancing in parallel rows. Cytoplasmic vacuoles, small, clear areas, windows into the cell's activities, possibly indicating phagocytosis or self-cleaning. Hypersegmentation, witness the elegant dance of nuclei with more than 5 lobes, neutrophils truly expressing themselves. Pycnosis, nuclear changes leading to shrinkage and denser nuclei, signs of impending changes. 4. Clinical significance, these changes in neutrophils aren't mere visual spectacles. They carry profound insights. Reactive neutrophil morphologic changes can signal various conditions, like bacterial infections, sepsis, and even the miracle of pregnancy. The intensity of toxic granulation might whisper the degree of inflammation in a patient's story. 5. Cytoplasmic vacuolation, as we peer into the microcosm of neutrophils, we encounter the enigmatic cytoplasmic vacuoles, those tiny, clear spaces within the cell's domain. They're rarer than their counterparts, the toxic granules and dull bodies, but their presence is captivating. These vacuoles are messages in a cellular bottle, often indicating phagocytosis, be it of the cell's own components, autophagocytosis, or of extracellular materials. Autophagocytic vacuoles, measuring about 2 micrometers, are sprinkled throughout the cytoplasm like stars in the night sky. But what summons these vacuoles? Think of drug administration, like sulfonamides or chloroquine, the artifact of storage in EDTA, autoantibodies, acute alcoholism, or even exposure to high doses of radiation. 6. Phagocytic vacuoles, enter the realm of phagocytic vacuoles, evidence of battles waged within the neutrophils realm. They often appear in septic patients like tokens of war, indicating the cellular struggle against invading bacteria or fungi. These phagocytic vacuoles are larger, up to 6 micrometers, and often dance alongside the majestic toxic granulation. But beware of their appearance without the company of toxic granulation or dull bodies, for this might signal an artifactual cause. Time of blood collection versus smear preparation time could hold the key. 7. Ehrlichiosis and anaplasmosis, tick-borne illnesses are on the rise, introducing us to cases of ehrlichiosis and anaplasmosis. These tiny organisms, Ehrlichia and Anaplasma, carve a niche within neutrophils and monocytes, forming clusters known as morula. In these infections, leukopenia, thrombocytopenia, and liver enzyme elevation often play their roles. Timely diagnosis is paramount, with antibiotic treatment, doxycycline, acting as the savior against potential complications. 8. Pycnotic nuclei, as we venture deeper, we encounter pycnotic nuclei, ominous signs that cellular destiny is at hand. These nuclei signal impending cell death, as nuclear water evaporates, and the chromatin takes on a dense and somber hue. Yet, don't confuse pycnotic nuclei with the necrotic nuclei of the deceased, it's a dance of transformation, not the finale. 9. Degranulation, amidst this intricate symphony, activated neutrophils and eosinophils dazzle with their degranulation, a burst of activity that serves as a testament to their commitment to the cause. Both primary and secondary granules unite within phagosomes, while secondary granules take flight into the extracellular realm. But, a cautionary note, eosinophils, delicate souls, might display their degranulation during the blood film preparation process. 10. Cytoplasmic swelling, neutrophil anisocytosis. Lastly, witness the phenomenon of cytoplasmic swelling, an unorchestrated dance that results from osmotic changes or increased affinity for the glass slide during blood film preparation. This symphony of variation, known as anisocytosis, showcases the diverse talents of these cells. Our journey continues, propelling us into the realm of monocytes, those steadfast defenders with their own stories to tell. Monocytes. 1. Occasional immature monocytes. In the symphony of infection and inflammation, a rare phenomenon emerges, occasional immature monocytes making an appearance in the peripheral blood. This phenomenon, though less common than its neutrophilic counterpart, is a part of the cellular orchestra's repertoire. Unlike the more frequently observed neutrophilic left shift, this occurrence reminds us of the intricate balance that our immune system maintains. 2. Reactive changes in monocytes. Behold the dynamic world of monocytes, a realm of cellular adaptation and response. Monocytes, those defenders of the immune realm, can undergo reactive changes in various scenarios, during infections, in the recovery from bone marrow aplasia, and even after a dose of GM-CSF therapy. Witness the transformation of their nuclei, thin and band-like in certain areas, mirroring the concept of segmentation. Their cytoplasmic realm expands, embracing more granules, showcasing phagocytic prowess through vacuolation, intracellular debris, and even irregular borders. 3. Large numbers of immature monocytes enter the stage of hematologic neoplasms, the domain where the abundance of immature monocytes unfolds. This captivating phenomenon often graces neoplasms that embrace the monocytic series, a testament to the intricate dance of cellular transformation. Lymphocytes, understanding reactive changes. When it comes to reactive morphologic changes in lymphocytes, a variety of terms have been used over the years. These include variant lymphocytes, reactive lymphocytes, effector lymphocytes, transformed lymphocytes, Turk cells, Downey cells, immunoblasts, and atypical lymphocytes. However, the term atypical is often used but might not be the best fit. It implies abnormality, when in reality, these lymphocytes are responding normally to antigens. So, what exactly are reactive lymphocytes? These are the result of intricate morphologic and biochemical processes that occur as lymphocytes interact with antigens in peripheral lymphoid organs. Activation of B and T lymphocytes leads to a remarkable transformation. Small, resting lymphocytes evolve into larger, proliferating cells that make their appearance in the peripheral circulation. Diversity in reactive lymphocytes. Reactive lymphocytes present a diverse population, showcasing a range of shapes and sizes. There's a noticeable variability in the nuclear to cytoplasmic ratio, nuclear shape, and even the clumping pattern of chromatin within reactive lymphocytes. One prominent feature of reactive lymphocytes is their basophilic cytoplasm. This feature can vary in intensity within and between cells. In some cases, nucleoli, which are distinct structures within the nucleus, might be visible in reactive lymphocytes. Interestingly, certain reactive lymphocytes can even resemble plasmacytes, and these are known as plasmacytoid lymphocytes. It's vital for medical professionals to grasp the meanings behind these terms used to describe reactive and potentially malignant-appearing lymphocytes in white blood cell differentials. Remember, the term atypical doesn't necessarily imply malignancy here. It's a morphologic term used to depict the reactive nature of these lymphocytes. Did you know that most individuals carry a subclinical infection of the Epstein-Barr virus? This virus's presence is linked to various health conditions, some benign and others more concerning. However, only a handful of diseases are definitively proven to be caused by EBV, and one of these is infectious mononucleosis. Enter infectious mononucleosis, also known as IM. While primary EBV infections in childhood often go unnoticed, in adolescents and adults, they can lead to the development of this intriguing condition. The onset of infectious mononucleosis comes after an incubation period of about 3 to 7 weeks. During this time, the virus attaches itself to B lymphocytes through a specific process. IM sparks a cellular response that involves the activation and proliferation of natural killer, NK, lymphocytes and specific T cells. This immune reaction kicks into gear as a response to the infection of B cells. When infectious mononucleosis strikes, it brings along a set of common clinical symptoms. These can include a sore throat, fever, chills, cervical lymphadenopathy, fatigue, and even headaches. Hematologic findings in IM often mirror those seen in various viral infections. You might notice an elevated white blood cell count, along with absolute lymphocytosis and a diverse range of lymphocyte morphology. While complications of IM are generally mild, they might include challenges such as hepatosplenomegaly, hemolytic anemia, and moderate thrombocytopenia. Occasionally, more severe complications might arise. These can include aplastic anemia, disseminated intravascular coagulation, Guillain-Barré syndrome, or even other neurologic complications. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.